Hello, everybody, and welcome to the Smart Human Podcast. Today, I have the pleasure of talking with Dr. John McBurney, who is Clinical Assistant Professor of Neurology at Edward Via College of Osteopathic Medicine, as well as Chief of Inpatient Neurology and Medical Director of the St. Francis Stroke Center in Greenville, South Carolina. Today, we're talking integrative neurology, COVID-19, especially over the past year and a half, as well as brain health. So stay tuned. Hello, everybody, and welcome to the Smart Human Podcast. Today, I have the pleasure of talking with good friend and colleague, Dr. John McBurney, who is a clinical assistant professor of neurology at the Edward Via College of Osteopathic Medicine, as well as chief of inpatient neurology and medical director of Secours St. Francis Stroke Center in Greenville, South Carolina. Thank you so much for being with us, John. I really appreciate you taking the time.
Well, thank you for asking me to speak with you, Haley.
Well, I think a few weeks ago I had called you about a patient of mine, and we were going back and forth about an unusual case from one of my COVID-19 long haulers. And after I got done talking to you and you were sharing with me sort of your recent experience with two pregnant COVID-19 patients, I really thought to myself, why am I not having John on to speak and talk about some of the stuff he's been seeing and what he's been doing? So it really kind of opened my eyes to what you could offer this audience in terms of your insight. But before we get into sort of a heavy topic, I really want to go back a little bit. Tell me a little bit about, maybe this goes way back. Tell me a little bit about how you ended up in neurology as a field.
Well, that's an interesting story. And in medical school, I became extremely interested in psychiatry, and honestly, I thought I was going to become a psychoanalyst. I went to medical school at Emory, and at that time, there was the Columbia University Psychoanalytic School had partially relocated from New York to Atlanta to Emory. And so I met these really pretty compelling psychiatrists. I did a really unique elective as a senior medical student where I had two patients in insight-oriented psychotherapy, 1 hour a week, and had an hour of supervision with a young psychiatrist who was the head of the drug and alcohol unit at the VA in Decatur, but was himself a training analyst and flew back and forth to New York City to get supervision with his training cases. And I read really extensively about psychoanalytic theory. I read pretty much all of Freud's writings, read a lot of Anna Freud. I got into the ego psychologist. I stumbled onto this modern psychoanalyst named Heinz Kohut. And then I showed up as a psychiatry intern at Walter Reed. And by the time I got there, with all of those experiences, I was really beginning to question whether I wanted to do psychiatry. I'd done such a deep dive into it. I saw that I didn't see that this psychoanalytic school, which is really a psychology school of thought, was necessarily best served by being an MD. I didn't see how I could really compete against psychologists. And I started my internship on neurology, which I'd done a lot of because I thought that psychiatrists needed to know a lot about neurology. And I had a really good experience, and I just literally flipped. I flipped my commitment my first couple of months of internship to neurology. And, part of it, I just thought, I enjoyed neurology, and I thought it was intellectually stimulating. And it was interesting. I thought I was pretty good at it. And so it infuriated the psychiatry department. They wouldn't talk to me after doing that. And so I flipped. Now, I've often said that if I'd known what neurology was going to turn into, I might not have done that. In fact, I used to say if I'd known neurology was going to be as hard as it has proven to be, I would have become an orthopedic surgeon, because at least I would have made a better living. But yeah, that's literally my story. And so, I just jumped from one path to another and just have continued down it for the last 40 years.
Well, 40 years is a long time, and you've seen a lot. You've seen a lot, and I bet you've seen enough in the last even 2 years of this pandemic to share. I'm curious to know, after, having done maybe 35 years of neurology and classic Western medicine, what made you decide to go in the direction of integrative or a more holistic approach to neurology, which is an interesting kind of twist?
Honestly, it was because we were starting to see what has turned into an explosion of stroke among young people. And I just had this feeling that we were seeing such a tidal wave of ill health in the population, and that by the time patients got to me, the therapeutic options were just too limited. I felt like I was seeing disease way too late to really be able to intervene in a meaningful sort of way. And I felt like there had to be a better way to look at the antecedents, look further upstream. And so I did this yoga retreat, and the part of it, we had to pair up into dyads and do discussions about things. And I wanted to somehow figure out a way to combine my interest in yogic practice with what I did in my day job. And so the young woman that I was talking to, Catherine White, her best friend and roommate from undergrad at Sewanee, is an anesthesiologist at Vanderbilt, and she does pain management. And at Vanderbilt, all of the pain management starts in the Integrative Medicine Center. They find that most patients don't need to see a neurosurgeon, they don't need an operation, they don't need an injection. They need to really address the way they're living and their response to their pain. And so she put me in touch with her, and I talked to her. I talked with the director of the Integrative Medicine Center there. And my original goal, and it's one of the things that I stated, in the first week of fellowship, was to try to get the necessary training to found an integrative medicine center at the hospital system that I was employed by at that time. We came really, really close. We had a lot of committee meetings. We came within a hair's breadth of having a campus for it, but ultimately nothing really panned out with that. And it was partly my frustration over that led me to leave that job.
Yeah, so basically frustration is what we often hear from our colleagues, right? About,
absolutely.
It's sort of the common thread that ties us all in any field within medicine, or I guess any healthcare professional, to kind of move in a direction of nutrition and diet and understanding how lifestyle. So that rings in my ear to be true. Can you just tell our audience, since your history is so strong in stroke care, what is a stroke? Tell the audience what a stroke is.
Yeah, stroke is a brain disorder, usually, almost always brain disorder, caused by either a lack of blood flow or hemorrhage. About 80% are caused by a lack of blood flow to portions of the brain that result in damage to the portion of the brain that doesn't have blood flow to it.
And you can have a stroke that's either a blood clot, which means like a clump that's blocking the vessel, versus a bleed.
Right. So we broadly divide strokes into ischemic strokes due to lack of blood flow, and hemorrhagic strokes or cerebral hemorrhages. The ischemic strokes are much more common. They're usually either caused by blood vessel problems or by emboli, solid pieces of clotted blood that arise within the vascular system, often from a proximal source, such as the heart, such as from atrial fibrillation. Vessel disease can either be atherosclerotic, large vessel arterial disease, or small vessel disease, which is usually caused by longstanding high blood pressure and diabetes, which causes a series of pathological changes in the vessel wall. These very delicate, small, penetrating arteries deep within the substance of the brain. Other, rare types of stroke can include venous thromboses, which are very prone, as you could imagine, if you've got a continued blood flow into the brain, but the blood can't get out, that's very highly likely to cause hemorrhagic infarction, which is a little different from primary hemorrhage, which is just a blood vessel rupturing. So yeah, I've gotten more and more into stroke. That's been, really the gravitational pull within neurology. We've had probably as much or more progress in stroke neurology as any other field. Stroke is an enormous public health problem. It's the leading cause of long-term disability in the United States. It's either number one or number two cause of death worldwide, depending on whose figures you look at. It's now gone from being the number two cause of death in the United States to the number 5 cause of death, which is a tremendous accomplishment in this century. But it's just such an important area. If you're a neurologist, you're always swimming, I think, against the tide if you're not involved with stroke. Honestly.
So interesting. You said that it moved from 2nd to 5th place in terms of cause of death. So what do you attribute that to? Better understanding, better marketing of some of these stroke prevention programs? Or do you think people just are waking up to some of the lifestyle effects?
I think the biggest part has been primary prevention. It's been aggressive identification and treatment of hypertension. It's amazing that we've been able to do that, accomplish that, even as rates of diabetes have skyrocketed. Mm-hmm. So it just shows how important high blood pressure is in the pathogenesis of stroke. I think the widespread use of statin medications has made a big impact as well.
And those are the people that have already underlying high cholesterols that are not being managed through lifestyle, essentially.
That's right. But I will say that, especially for high-risk individuals who have some declared cardiovascular disease, that the current guidelines for LDL cholesterol below 70 are stringent enough. It's really hard to get there without medication.
Yeah. No, I agree. I mean, that, and that goes to the idea of integrative medicine in a way, because we're really talking about how do you integrate the best care into lifestyle changes as well as medicinal needs. And I think that's a very even-handed way to look at that.
Well, there's been this tendency that they remarked on in the fellowship about how many integrative types of approaches, once they become mainstream and accepted, are no longer considered to be integrative. And so a great recent example of that is the Mediterranean diet. That is now our sort of default recommendation for secondary stroke prevention from a nutritional standpoint, not a low-fat diet. And there's no controversy about it. Back when we were fellows, that was perceived as being highly controversial, and you'd have people like Dr. Weil, who had done deep reading of the literature and really understanding trends, saying we're not really sure that this low-fat emphasis that's sort of the standard recommendation is really the best way forward. And, you have to eat something, and eating a bunch of carbohydrates, especially, simple carbohydrates with high glycemic index and high glycemic load is really not the best way forward. And then, of course, all the PREDIMED studies, and it's not just a PREDIMED study. There's a dozen studies out of that have shown the various benefits of that dietary pattern. And now, it's not something we really think twice about. It's in our SMART phrases for treatment recommendations for consults.
Yeah, I think it's fascinating because even you coming from the angle of the brain, studying the brain, studying neurology, and I'm coming from the area of rheumatology and autoimmune disease and immune system disorders, and yet they converge on some very common recommendations, that being the Mediterranean diet, because Absolutely. It has so many anti-inflammatory effects, which of course can affect the immune system. And to clarify just quickly for the audience, the Mediterranean diet is composed of, I'm sure you could whip this out in 2 seconds, but what are the main, what's the premise of the Mediterranean diet as we're taught and as you know it?
Well, I think it centers around healthy fats, and it de-emphasizes carbohydrates, and that really animal-derived protein is really viewed more as not a main course, but as an accessory to the meal. So you might have meat a few times a week, not at every meal. You don't view fats are not viewed as just a single thing. But the omega-3 polyunsaturated fats are a big component of that through olive oil and other healthy fats. When protein is consumed, it's consumed, more in the form of, fish than red meats. And
yeah, those are actually excellent. And I mean, and if you look up for those listening who want to look up the Mediterranean diet, you can also look up Dr. Weil's anti-inflammatory diet, which is essentially utilizing Mediterranean diet. But there's just enormous amount of studies showing the health benefits of a Mediterranean diet. But it doesn't mean a bowl of pasta and like a little bit of olive oil and like a couple, pieces of fish and maybe a piece of fruit. It's really more the opposite. It's more plant-based in general, high-quality plant-based, whole foods, whole grains, and then sort of narrowing on this sort of pyramid up to, the condiments, which are more like, dark chocolate, meat, red meat, and kind of limited on the dairy as well, unless it's really high quality. So anyway, that can be found online for people who are interested in the Mediterranean diet.
Yeah, I think the concept that it's whole food based is really critical. I was in Minneapolis, and there, Minneapolis originally came to be as a wheat processing center. And it's really interesting. On one side of the Mississippi River are the Pillsbury mills. And on the other side was another rival mill that was the Consolidated Mill, which eventually became known for marketing gold medal flour. Mm-hmm. And, flours like that are highly explosive when they get into the air. So there was in the gold medal, flour mill blew up. And now they've turned it into a museum. And when you walk into the museum, there's this big plaque that says, "It all started here." And up until that time, people had small amounts of flour because the production of flour wasn't mechanized, but it became highly industrialized, highly mechanized. And so the amount of flour that people consumed skyrocketed in the 19th century as a result of all of that. And so in effect, a lot of the problems that we see with health today really did start then. And so they didn't know what they were saying, but I always regret that I didn't take a picture of that plaque to use in lectures, because it really did. There's a big difference between a wheat berry and a crushed wheat berry that's been turned into flour. Yeah,
well, you'll get maybe one of the listeners listening is from that area and can text me a picture and I'll pass it along. But yeah, I mean, there's a lot of ironies when we look back. I mean, when I was at the American Academy of Natural Museum, I think it was American History Museum. I don't know, I'm losing my mind. But anyway, in New York City, and there was there's a bug exhibit, and who is it sponsored by but Orkin? So it's like the irony is just, I can't even keep up with them, or McDonald's and, the first floor of a children's hospital. But anyway, I'll probably get sued for this. But anyway, so I wanted to ask a couple things. You were involved in integrative medicine, I guess now since 2014, since we graduated. And your experience really has led you even further down the rabbit hole. You were asked by Dr. Weil to write or co-edit and co-write with another wonderful neurologist, the Integrative Neurology textbook for his academic series, the Weil academic series. So tell me a little bit about how that came to fruition and what's been your experience since it was published.
Well, I was approached during the final week of fellowship in 2014 to consider taking on that project. Victoria Macy's brought me over and introduced me to Andy, and we had a conversation. Andy gave me his card, which I carried for a long time, but I wasn't really in a position to take on a project like that at the time. Like a lot of us, my sense of dissatisfaction with my job at the hospital, where I never could quite get over the hurdle of getting the Integrative Medicine Center started, and my expectations really mounted, and so I quit that job, and we moved from South Carolina to Portland, Oregon, where I sort of conflated the fact that Portland's a very progressive kind of place to there would be some role for me to kind of get that kind of effort established, and that turned out to not be true there either. Although I did stay involved. I did some teaching at the National College of Natural Medicine, the naturopathic school there. I did their neurology and taught them about seizures and stuff like that. And I thought that was really important because in Oregon, naturopaths are allowed to be primary care doctors and get Medicaid numbers. And, I thought it was really vital that they have the basics down. So, that led to a period of time where, my life was kind of unsettled. I traveled around doing locums for 2 or 3 years. I really wasn't a time to take on a major project like that. But then I met Ilene Ruhoy, my wonderful co-editor, through LinkedIn, of all things. And, I said something to the effect that I was the first neurologist to graduate from the fellowship, because that's what I'd been told. And so Ilene said, well, I graduated, like 5 years before you did. And she and I have had conversations about the fact that, Andy and Victoria and everybody involved with the program seemed to miss the fact that she was a neurologist and had forgotten about her to a degree. And I sort of think some of that reflects, I don't want to accuse anybody of anything bad, but I just think that sometimes women get overlooked. Once I had a partner, once I had someone that I could take this on with, and with her, incredible background, she's an MD PhD, she has a PhD in environmental toxicology, she's practiced integrative neurology in a freestanding clinic in Seattle for a decade. Was a faculty member at the University of Washington. She's a child neurologist, so she has that developmental perspective. And she just knows everybody. And that really, putting together a multi-author textbook, a lot of times it's like designing a really great dinner party. You have to have a good guest list, and you have to get people willing to say, yeah, I'll come. Yeah, I'll write a chapter, because it's a lot of work. And so we put together a proposal. It was reviewed. It was revised. We got people to accept our invitations, and then it became a process of managing, getting those chapters in, and, getting the references sorted out. It's just a lot of mechanics to it at that point. But people put so much effort into it, and, I was really very, very concerned that we just weren't going to have much of a story to tell, that we were going to wind up with a really slim volume, that we weren't going to have that much. And we actually had to negotiate 2 or 3 times to have a larger book length than the contract called for, because we wound up with, initially, I think, about 600 pages. So it's the longest volume in the Weil series.
And for those listening who haven't heard of this Weil series, Dr. Andrew Weil began this, I would say, about 15, 20 years ago, maybe. And I know that this is the 14th book in the series is yours.
That sounds right.
14th. I think ours was 13th. But, the idea is that there's an integrative pediatrics, integrative women's health, integrative cardiology, integrative gastroenterology, and all of these textbooks have contributing authors and really just talk about the integrative approaches along with Western approaches to many, many of the most common health ailments that the population contends with. And so tell me a little bit about what's in the book. Tell me how the chapters are laid out and what listeners, if they were to actually go find this book, would learn from it.
Yeah, so I went over and got my last remaining copy off the bookshelf. So we started off the book with a chapter that I thought was really important on stress and burnout in neurology. You know, stress and burnout in medicine were, even before the pandemic, just a big problem. And consistently, the studies that look at this show that neurologists are either the most or among the top 2 or 3 specialties likely to experience burnout. So Marsha Schneider, who's a psychiatrist in Pennsylvania, I believe, who was once the head of behavioral health for a big hospital system in Pennsylvania, and went through a series of physical crises that she talks about in her chapter that sort of turned her world upside down. And then so she wound up, it's really amazing, she wound up going to back to school and got a master's in positive psychology with Martin Siegelman at the University of Pennsylvania. So she's a psychiatrist who has gotten into the whole thing of positive psychology, and her clinical effort is really helping physicians with stress and other types of problems. So she really mostly treats physicians. So she wrote a concise, fairly concise chapter that was a condensation of a book that she's written on this subject. We then have a great chapter by one of the faculty at Emory on nutrition and cerebrovascular disease, integrative headache management, traumatic brain injury, approaches to look at cognitive impairment and dementia by Nancy Eisenberg in Seattle, who's also at the University of Washington, behavioral neurologist. A chapter on Parkinson's disease written by movement disorders neurologists who integrate a lot of integrative approaches, including nutrition, Tai Chi, other types of modalities into their comprehensive management of Parkinson's disease in large academic health settings, multiple sclerosis, neuropathic pain, sleep disorders. There's a long chapter on Ayurveda and neurologic disease, a good chapter on autism spectrum disorder, a really fascinating chapter on the endocannabinoid system, how that changes in aging and in neurodegenerative disease. And then a chapter by your friend and colleague, Fred Vomsal, and also Tom Zeller on endocrine disruption and brain behavior effects based on thyroid and sexual differentiation. That's pretty dense and pretty provocative chapter. And then finally, what I think is probably the best review of acupuncture and neurological diseases, written by one of the faculty at Oregon Health Sciences University, Alexandra Dimitrova, is the final chapter, and it's a fantastic look at acupuncture that actually makes a lot of sense from a Western perspective, and she has data, and I mean she's an NIH-funded researcher. Her main research portfolio is on acupuncture and neurologic disease, and she's using acupuncture to treat patients with neurological illness.
Isn't that fantastic?
So this is the book. It is available on Amazon. I think we have 6 5-star reviews, and I recommend it highly.
Yeah, no, listen, if only Western medicine and Western docs and Western, or allopathic or conventional, however you want to call them, as you and I are, but got a hold of some of this information, I think it would really open their minds to the availability of other tools out there that serve their patients. So, thank you for writing that book and co-editing it with Dr. Ruhoy, because I think this is an incredible contribution to healthcare and to human health. So that's wonderful. I wanted to now jump into, saving sort of the tough stuff for last. Tell me a little bit about your experiences over the last year and a half as the director of inpatient neurology at a major institution in Greenville, South Carolina, which is an area that's, a southern state, and has different philosophies and different personality than some of the northern states. So jump in and tell me what your experience was, if you don't mind.
Well, I was getting my thoughts together in anticipation of our conversation yesterday. I spent the last 7 days working inpatient. And I was talking with one of my friends who's pulmonary critical care, who's about my age. And, we both agreed that, in the 40 years that we've been practicing, that in the last year and a half, we've seen more death and suffering than we have in the previous 38 and a half. It's horrible. Greenville County, Greenville City has been hit particularly hard. We consistently have the highest moving 7-day averages in the state. Our numbers are coming down, but we spent a lot of time at the 100 per 10,000 daily new cases. St. Francis is a small hospital, about 200 beds. We peaked out a couple of times at 150 COVID inpatients. The last week, not this past week, but the week before that I was doing inpatient, there were 30 COVID deaths in that 7 days, including 6 on the Sunday before I went off service. I realized after the first wave, based on, part of this illness that I get to see, that I'd never seen a patient survive COVID. I don't see the patients that come in and get put on high flow O2 for a few days and get remdesivir and Decadron and then go home. That's not the part that I see. And the positive thing, I've never been threatened by a patient. I've never been assaulted by a patient. Most of my patients are comatose or dying or dead. This past wave with Delta has absolutely convinced me that it's not only dramatically more transmissible, but it's much more virulent. In the first wave, we saw a lot of old people that died after very, very prolonged ICU stays, basically a multi-organ failure. And it was horrible. It was. You've never seen such horrible mortification of the human flesh. I remember one patient in particular who was an ophthalmologist. He was 72, still practicing, and he'd been in the hospital for 6 weeks. His family hadn't been able to visit him. I went back and actually looked up his ER visit when he came in. And his chief complaint was, I think I picked up something at work. And, that's particularly poignant since the original description of what appeared to be a SARS-like respiratory virus in Wuhan, China, was by an ophthalmologist. And ophthalmologists and dentists and people who get right in people's face to do their job have a very, very high rate of high risk. So anyway, when I met him, he had a trach and a peg and bilateral chest tubes. He was a big, tall man, maybe 6'5", barely fit in a hospital bed. But he was skeletal. And he was markedly rigid. And, they had finally decided this was when we were still learning. And one of the things that we've learned is that just because you can detect virus by PCR doesn't mean that it's viable virus. So, they finally had declared him, even though he was continuing to test positive, as being non-infectious, and he was moved out of COVID ICU, and they requested a neuro consult for prognosis. And of course, then his family got to see him for the first time, and they withdrew support, and he died almost instantaneously. It was just horrible. But that was sort of what we saw in the original waves of the original version of this virus. And then the B117 virus was a little worse. But then, I was reading about Delta, and I was, my threat radar on this stuff is really turned up to an extremely high level. And I was saying, when Delta gets here, we're in big trouble, because we just don't have, even to this date, we don't have 50% of the population vaccinated in the state. So what we're seeing now is that people die of overwhelming viremia. And so it doesn't take very long for that to happen.
You're saying that the replication is so rapid, it's so virulent, it's easily transmissible that by the time people actually become relatively symptomatic and they have underlying potential issues, it's harder to turn back the disease.
Or they don't have to have
prognosis.
underlying potential issues with Delta. They really don't. And it seems like they declare themselves early on. Either they're going to have a mild illness, and they either don't come in, or they're just there for a couple of days, 3 to 4 days, and then they get to go home. Or they take a turn for the worse, and then it's just Katie bar the door, and so in a week they're dead. They don't go through liver failure, kidney failure, on dialysis. They die, and they die from cardiac arrest. I mean, it just kills people so fast. I mean, before all of this happened, code S's, meaning, acute stroke alerts, were much more common than rapid responses, and dramatically more common in our hospital than code blues, for respiratory arrest. And now the exact opposite's the case. The rapid responses.
So it's code blue all the time.
Code blue all the time. Yesterday, there was the 25-year-old who had been in the hospital for about a month with COVID, who had a cardiac arrest the day before, and who was really in big trouble. She was on 4 pressors with low blood pressure, and her pupils were blown. The question was she already brain dead or not? And, we had a hard time being sure, because her blood gases were so bad on 100% oxygen. Her PO2 was only 60, but her PCO2 was 72. So I couldn't really safely do an apnea test. I probably would have precipitated another cardiac arrest, and she was full code. And she was too unstable to take for a blood flow study. We tried to do an EEG, which was just completely obscured by electrical artifact. I mean, this woman has like every pump in the world hanging. And so we wound up doing transcranial Doppler and showing that she did have still some blood flow, but she died overnight, 25.
I mean, what does that do to a clinician like yourself? I mean, I'm not even in the hospital. I'm outpatient.
Yeah.
What does that do to someone who's the director of neurology, especially with so many stroke cases, so many microthrombi, which are little mini clots that we now are associated with COVID-19 infection, in older people and younger people. Tell me a little bit about what's that done over the last, and you even talked to me about 2 pregnant women. Remember, we were on the phone, and I couldn't believe that story either.
Yeah, and on 1 week, we had 2 unvaccinated young women in the 3rd trimester of pregnancy develop COVID, go into premature labor, have to be delivered by emergency C-section. So their babies are in the neonatal ICU. They were transferred across town to the COVID ICUs on ventilators, and one died later that week. Yeah, it's brutalizing. I mean, I am so unbelievably sick of the constant death. Burnout. There are 3 main components of burnout. One is depersonalization, and that's an extreme ego defense mechanism from my psychiatry days. So that means that you don't view your patients as truly fully human. You depersonalize them. They're just a disease. They're just a patient in room 3301 or whatever, but they're not a human being with family and story. So they're having to use that just to maintain their sanity. They can't really get deep into connecting to the humanity of their patients on a regular basis. So depersonalization, devaluation of the personal accomplishments that you really make. And that's one thing that I'm really trying to work on, and to think about even if there are only small things that I do to contribute, maybe not to the welfare of the patient, but like the delightful family that were the mom and dad and aunt of that young 25-year-old that I sat down with for an extended period of time yesterday, sort of talking them through where she was, talking about goals of care, sort of doing my own version of palliative care, in all honesty. And then there's emotional exhaustion, and I think we're all way past emotional exhaustion. We've just pretty much had it, and accompanying that sense of emotional exhaustion is no small amount of anger, because we've only had 5 vaccinated patients die at St. Francis. We've had a lot of death, but only 5 patients who've been fully vaccinated, most all of whom had pre-existing major problems. So it is a feeling that this is all just unavoidable. And there have been, not at our hospital, but at other hospitals in the community, deaths that play out where unvaccinated patients who are heavy into COVID denial and anti-vaxxers, who are now suing because their loved one, quote, didn't get correct care, unquote, meaning they didn't get ivermectin. And they're now suing both the physicians and the hospital systems that took care of them. Now, hopefully that won't go too far. I think it would probably be thrown out of court, but that just goes to show, we don't have psychiatry in our hospital, so we have these little robots that we do telepsychiatry. Mm-hmm. And, one of the robots came back from the COVID floor broken. So patient got mad and tried to hurt the psychiatrist on the other end of the screen.
Wow.
So, and that's the other thing is, when they have to call security, it's code gray, and code grays have become more commonplace.
Yeah, it seems like it's playing out there in what we're seeing a lot on even the mainstream news when we're talking about the frustration, not only of just, medical people who are burnout and tired and exhausted and frustrated with people who don't want to move towards vaccination. But even every job out there, flight attendants, and the service industry and restaurants can't even hire because, clientele are so angry and kind of mean to servers. It's sort of this ripple effect of being unkind because everyone is so stressed. And so
there's no question.
It's remarkable that you're doing what you're doing. And when you're this burnout and you're managing such life and death cases almost all the time, not just on an occasion, what do you do to pull yourself out? What are your releases for your integrative medicine therapy that you would do for yourself, that you would tell your patients as well, and friends and colleagues?
Well, one thing is that I think you simply have to have time away from work. You can't stay in it constantly. That's one of the real lessons from burnout, is that it's constant, unremitting stress. We're as humans designed to deal with periods of stress, and then there's a period where you recover from the stress. But if you're constantly held at that highly stressful level, then that's what really starts to cause physiological and psychological damage. And so I'm really very, very lucky that in my current job, after I am on for 7 days, I'm off for 7 days. So I have a little mini vacation, every 3 weeks. And mm-hmm. I don't think I could have made it through this without that. I just don't. If somebody said, you're going to have to work, every week, one way or another, I just could not handle that. And I've actually decided that in 2022, I will definitely retire. And I'm going to try to go to part-time work where I work 1 week and then take 2 weeks off and then work another week, and just like that. So I get 2 out of every 3 weeks away from this nonsense. But if we do get into a situation where we get back into just rolling, waves like we've already been through, the 2 really big ones, then I don't even think I can do it part-time. I think I'm going to have to step aside completely.
Yeah, and it's sad to hear because we have so many talented physicians, leaving the workforce, even pushing it to leave early because of just what's been going on in the last year and a half. I don't think people realize the sort of the weight on the healthcare system, nursing too, and respiratory techs and custodial as well. But when I hear someone like yourself with such an incredible medical training and contributions, it's kind of eye-opening, you know?
Well, I'm 66. I'll be 67 before too much longer. My plan was to probably retire when I was 66 and then to work part-time until I was 70. And so this is really just sort of forcing the issue of the plan. The big thing that for us, for Jill, my wife, and I as a couple, that's been eye-opening is, how ultimately all of these decisions about following science and following public health regulations or lack thereof where we live is really kind of exposed some pretty ugly truths about this area. Certainly it has done the same to the country as a whole, I think, but it's pretty extreme here. And we're not sure that we can or want to stay in the South for that very reason. And we're starting to sort of think about what our options are. We've developed some ideas about, what a place that we would feel comfortable living in would look like. And some of it has to do with, the shared values that result in, that are expressed in the political choices, and that we just, we can't stay in a place where when the governor, in having a discussion about CDC recommendations regarding vaccination, states that the vaccines work, but that people need to consult all the sources of information that they have access to in making a decision about getting vaccinated. And my immediate response was, do you mean they should look it up on Facebook, or should they just call Q directly? And that's the governor of the state of South Carolina said that. And so, again, we haven't made any decisions. One of the thoughts that we've had is that if I do get approved to work only 1 out of every 3 weeks, that we would use the time that we're off to travel around in order to kind of come up with some better ideas about where we could live. But Colin Powell dying this morning from COVID-19, fully vaccinated. I mean, he's somebody that I had so much respect for. I was in the Army during Operation Desert Storm, and he was, in charge of someone that I had the very highest regard for. And we've lost so many great people, to this pandemic. But
yeah, that was this morning, and interesting. It is interesting you brought that up, because when I was going through your bio, I found out that you had a long history, not just being in the military, but also military awards that you've accumulated, commendations, Meritorious Service Medal, Legion of Merit. And then you went on to actually co-found the neurology residency at the Madigan Army Medical Center.
Right. Yeah, that was pretty crazy.
Yeah. But really sad and tragic about Colin Powell this morning. You've been through so much. It seems like, when I hear about the other side of your life, which is the incredible amount of biking you do and all the yoga, and your wife's training in yoga. And I really think about how you've embraced these other, these joys in your life to sort of compensate in many ways for some of this life of healing that could be so, chi sucking, so to speak. It takes the chi right out of you, the energy, the life force. So tell me a little bit about how you're now utilizing your joys of yoga and biking. And I know this is kind of an odd shift, but I want to pull out of some of this into what we can do, all of us, to help us from, keep from burnout and support brain health, and to, what are the top lifestyle recommendations you would give as a neurologist to help with brain support and preventing dementia and long-term risks?
Well, I would have to confess that for the last couple of years, my yoga practice has pretty much lapsed. I got the flu really bad about 2 years ago, and I was pretty sick for a couple of weeks, and I lost a lot of strength, and my practice wasn't the same. And I found it very hard to overcome my attachment to my view of myself as being really physically strong, and I was no longer nearly as strong. And then right on the heels of that, the pandemic hit and we went into lockdown and there were no classes. I was doing mostly home-based practice, but I really didn't even have a good place to practice. And so that part of my self-care kind of lapsed, and it's something that I do miss and I need to get back to. My upper body strength has definitely declined a lot. I had a little cardiac issue about 4 or 5 years ago that was part of a post-viral inflammatory storm. I'd gotten really, really sick, and then about a month after that, I had an acute coronary syndrome, had to have a cardiac catheterization and got a stent, had no definable risk factors. My HDL cholesterol was 82 on my admission lipid panel. I was told not to do anything to put pressure on my hands for 5 days after that, because they did a radial artery approach for my cath. But then on that 6th day, I did 2 hours worth of yoga, including 50 handstands, just to prove that I was still alive.
Oh my gosh!
But I can't possibly do those kinds of things now. But what I have gotten more and more interested in is my biking. One of the reasons we moved to Portland, Oregon, was I really wanted to experience bike culture there. I wanted to drive a lot less, and so we bought a small house in northeast Portland and Irvington, and I was able to bike to work. And ultimately that spring, I realized the only time that I was driving my car was to take it to the car wash to wash all the moss off of it from it just sitting there turning green. And our daughter needed a car because the car we gave her in high school was starting to die. So we put my car on a truck and shipped it from Portland to New Orleans, gave it to our daughter. When I did the title transfer, I'd driven 800 miles in that 9 months. Most of that was right after we moved there. So I pretty much have been living car-free since then. I've been at St. Francis now for almost 4 years, and I've not driven to work yet. And I don't even know how to get into the physician's parking lot. I one day last winter it was real icy, and Jill didn't want me to bike into work on a weekend when I was on service, so I actually hiked in. And then there's a new thing in biking called bikepacking, which is, roughly speaking, sort of the intersection of backpacking and mountain biking.
Oh yeah.
And so the other axis of that is bike touring. But I've really gotten into bikepacking. I just got back from a big trip in Pisgah National Forest, where we rode the rim of Linville Gorge, which is sometimes called the Grand Canyon of the East, and then dropped into another canyon called the Wilson Creek Gorge, and it's really Wilson Creek, so-called, is a wild and scenic river. It's really unbelievably beautiful, and to just be out in nature, moving under your own power in these really astonishingly pristine ecosystems is what's getting me through all of this. And in all honesty, at 66, I realized that I can't take for granted being able to do what I'm doing indefinitely. I was riding a heavily loaded bike up unpaved gravel roads in Pisgah. The top grade I recorded on that trip was 36% grade. Wow. It's straight up, and I know I can't take for granted that I can do that, and I don't want to just keep pounding my head against the wall doing medicine and miss out on these opportunities. I just want to explore. There's a new trail system that's under development, and they should be starting to release some of the trail guides called the Eastern Divide Trail, and that follows two continental divides, mainly the Eastern Divide of North America. It starts in Nova Scotia and ends in Key West, Florida. It's 5,500 miles long.
Wow!
It's the longest off-road biking trail network in the United States, and I don't say that I want to ride the whole thing, but I want to, it'll actually pass maybe 30 miles north of where we are. And I want to really get out there and explore that.
That's great. I mean, it sounds like nature's healing. I mean, as we have colleagues that have written books. Dr. Suzanne Hackenmiller, she wrote a book about nature therapy. It sounds like you're really embracing and have always been embracing. It sounds to me like your love of nature has been your tonic. So
yeah, it definitely is. It's definitely there. And I've gotten involved with a couple of nonprofits here. There's an organization called Bike Walk Greenville that works with city and county government to try to offer recommendations and plans and community involvement for improving active transportation options within the community. And then there's another organization called Momentum Bike Clubs, which works with at-risk youth through biking and mentoring to try to improve their outcome. And one of the areas I've become very interested in as a medical director of a stroke center is health disparities, and there are tremendous health disparities in stroke. Stroke rates among at-risk populations are really, really high. So especially among African Americans, the risk of dying from a stroke is about 50% higher than it is for any other racial or ethnic group. And it's clear that, again, thinking about going further upstream, that the antecedents begin in childhood and adolescence and young adulthood. We're seeing an explosion in stroke of the young, and it's all related to sedentarism, obesity, general ill health, shocking rates of diabetes, hypertension, and then ultimately what I have become is sort of an amateur epigeneticist. I'm very interested in trying to ground a lot of this, which falls roughly under the social determinants of health in science. And I believe that there are probably very important epigenetic mechanisms that underlie these health disparities. There's a very interesting article in the New England Journal in 1996 by Fong that looked at the risk of dying of cardiovascular disease in a group of adults living in Harlem based on the place of birth. And so if you look at the risk of African Americans who were born in the Southeast and then moved to New York versus those who were born in the Northeast and lived in New York, the risk of cardiovascular disease was dramatically higher in African Americans who were born in the Southeast. But what was also very interesting is that Caribbean-born blacks living in Harlem actually had slightly lower risk of cardiovascular disease death than whites. So what is it about that early experience? And moreover, in my view, and this falls under an area called social epigenetics, is what do the social conditions that lead to this. And I mean, if you look also at African Americans at every educational and income level, health outcomes are dramatically lower than they are for other ethnic and racial groups. Why is that? I think a lot of physicians sort of lapse into the sort of a lazy assumption, which is that it is, quote, genetic. If it's genetic, why does it vary by place of birth? And why do Caribbean blacks have essentially the same or slightly better cardiovascular outcomes than whites? Then finally, there's a study and published in Stroke. I mean, these are top-tier journals, New England Journal, and
Right.
also American Heart's premier journal for cerebral vascular disease called Stroke.
Right.
From Albert Einstein by Insewa that looked at the risk of death due to stroke between 2011 and 2015 and related that to the prevalence of slavery in those on a county level granularity in 1860. And so there's a phenomenon called the stroke belt. You know, this, stroke is much more prevalent in the Southeast, and there's actually a dose-related effect. And overall in the South, the risk of stroke is lower. But even contained within that is a disparity, which is that among whites, the dose effect was actually negative in terms of the risk of dying of stroke in those areas that had high rates of slavery. But it was all borne by blacks.
That's so fascinating. So this epigenetic exposure. So in case people who are listening don't know what epigenetics are, is that we're given a set of genes. We're born with a set of genes, which is a code for all of our physiology and our makeup. But epigenetics are the proteins, essentially the stop blocks that are sitting within the genetic code that either allow those genes to get expressed or not. And so our epigenetics are what can be modified through lifestyle, diet, nutrition. And what you're saying now, John, is even social determinants can affect the epigenome and whether or not certain diseases get expressed, because that can affect the genes.
Yeah. So in looking at it from the risk of cardiovascular disease, one of the candidate markers is line 1, which stands for long interspersed nucleotide elements. Those are diseases that are genes that are usually heavily methylated and therefore silenced, and they're often referred to as genetic fossils. They're kind of buried in our genetic code, and they may, in large part, represent prior exposure to retroviruses. But they were described by Barbara McClintock, and for which she won the Nobel Prize. But they're sometimes referred to as jumping genes. If they're unmethylated and they become active and they start jumping in and out, they can cause chromosomal breakage and lead to cancers. They interact with inflammatory cascades and pathways and lead to autoimmunity. But also they contribute significantly to cardiovascular disease risk. So any event that results in widespread demethylation will have the potential impact of turning on these very nefarious and injurious little snippets of genes. And the issue is that they're not uncommon. Line 1 is line 1 through line 3, but line 1 constitutes 17% of the human genome. So they're very, very abundant. And demethylation events have been described due to mass traumas. There's studies that show that the Holocaust was, exhibits multi-generational effects, probably through, epigenetic effects that result in increased risk of a number of bad health outcomes. The Danish famine at the end of World War II, where people were basically starved to death. And there's data from Scotland that show lower socioeconomic class people have lower rates of DNA methylation. And so, my theory, and also there's the whole issue of intergenerational and transgenerational epigenetic inheritance, which is that if you expose a pregnant woman who's pregnant with a female fetus to a horrific shock, then that results in epigenetic changes not only in the mom, but in the daughter and in the granddaughter. And so these changes can be transmitted multi-generationally, and they can look like a genetic issue when the problem is really an epigenetic issue. Why is that important? Well, we can't change our genes. Gene therapy hasn't really panned out, right? But we could certainly change our epigenome. And that's by addressing those social determinants of health. So I have this idea, and it may be pie in the sky, that we do a study looking at line 1 methylation in the adolescents that are involved with part of the Momentum Bike Club, to do a pre and post to look at their line 1 methylation to see if that improves. There's been one study in obese middle-aged women that showed that nutritional counseling and exercise improved line 1 methylation. So would it not be really exciting to show that we could show that a multifaceted program designed to address stress and sedentarism and improve physical fitness in adolescents also improved their line 1 methylation, and maybe would, when we talk about them being at risk, I mean, that's sort of a loaded term. We really don't like to use that, but one of the things that we know that they're at risk for is early cardiovascular disease, because we're seeing such a major increase in cardiovascular disease and stroke among the young. I mean, there was a 40% increase in stroke below the age of 40 over a 10-year period in the early part of this century.
Well, I think it's fascinating stuff. I mean, we talk about methylation issues when it comes to even chemical exposures, and you know that best because you wrote a chapter in Integrative Environmental Medicine, which is the textbook we did for the series, and you wrote a beautiful chapter on the effects of environment on Parkinson's disease development, Alzheimer's, dementia, and it was just a beautiful chapter. And so this concept of exposures, be it stress, be it chemical, all have effects on the epigenome potentially, and that can change this methylation picture and play out clinically into what diseases people express. But I want to kind of come to a close with the interview because we are going to, I mean, we could go on for hours, this we did on the phone, but I want to just end with something. Well, you did end with something positive. You're working with some incredible groups, and I want to get the links for these bike groups that you mentioned.
Sure.
So maybe we'll put those on the website so people can see how they can get involved with biking and also mentoring through biking and activity like that. Just to end this conversation, I wanted to ask some fun things. What's your favorite type of food?
New Mexican Southwest type food.
Okay, maybe that'll be in your future where you end up. And also, what's your favorite color?
Blue.
What's your favorite condiment for your food? Any type of food?
Probably Lusty Monk spicy mustard.
Oh, spicy. And also, what's your favorite pet, if you had to pick one?
Dog.
Okay, classic. John, first of all, thank you so much for spending the time and sharing with this audience. I'm sure this audience has not heard a lot from a practicing inpatient neurologist on many topics, including integrative medicine all the way through COVID. So thank you for sharing your insight and your knowledge, and for being such an active and important part of the healthcare community that you serve and all the places that you've served. I appreciate you. I think you're incredible. And I hope that, whatever you go on to do in your future, if you do retire soon, is filled with joy and happiness. I want to also let people know that, again, you did co-edit or co-write, I should say, the Integrative Neurology textbook for the academic Andrew Weil academic series with Oxford University Press, which I think is remarkable for people who are interested in learning more about integrative approaches to integrate into their Western medical care. And we will post links on all the cool stuff that you're doing to see if people want to get involved. Do you have anything else you want to share?
No, thank you, Ailey. It's a real honor to speak with you. I'm sorry for all the little technical hiccups earlier today. It definitely made me feel it's like, getting your parents to learn how to use their phone.
Trust me, I've had more than enough technical issues, and I thought to myself, my God, now I don't feel so dumb. So this is wonderful. I have a colleague who's just as stuck with this stuff as I am. But it worked out well, actually beautifully, and I'm really, really thrilled with our interview. So thank you so much for taking the time, John, and be healthy and well.
Thank you. Talk soon.